Welcome to today's webinar brought to you by OraSure Technologies Incorporated. OraSure Technologies is a global leader in oral fluid substance abuse testing products. Their unique assays provide accurate and easy-to-administer testing methods to help determine the presence or absence of drugs of alcohol in a person's system. Oral fluid-based testing products provide a simplified collection process, faster results, cost savings with minimal risk of tampering, and dramatically reduced risk of adulteration. The Intercept Oral Fluid Drug Test is an FDA-cleared laboratory-based oral fluid drug testing system that enables accurate testing for drugs of abuse, including marijuana, cocaine, PCP, amphetamines, and opiates. With a fast and easy-to-administer collection process, Intercept is ideal for workplace criminal justice, drug treatment centers, and clinical setting screening programs, among others. Today's presentation is entitled The Value of a Follow-Up Drug Testing Program in a World That Says You're Fired, and will be presented by Bill Current and Laura Lacey-Dashner. Bill Current is the president and founder of WFC & Associates, a national consulting firm that specializes in drug testing policy development and providing accurate and up-to-date state drug testing law information. He is the editor of the online Ultimate Guide to State Drug Testing Laws at statedrugtestinglaws.com and the publisher of the e-newsletter State Drug Testing Laws Monthly and the weekly e-news service Drug Testing in the News. He is the author or co-author of 10 books on substance abuse issues, including Why Drug Testing. He also administers the annual Drug Testing Industry Survey, now in its 15th year. Laura Lacey-Dashner is the Vice President of Business Development with the American Substance Abuse Professionals, ASAP. ASAP has provided substance abuse professionals, SAP, and substance abuse expert, SAE, evaluation since 1997. Ms. Dashner started with ASAP in August of 2003 after receiving her MSW from the University of Maryland with a specialization in EAP studies. She is a licensed social worker with 10 years experience acting as a DOT substance abuse professional, SAP. As an account liaison at ASAP, Ms. Dashner worked closely with transportation companies and EAPs to assist them in developing and implementing DOT-compliant SAP programs. In doing so, she has provided training on the DOT SAP return-to-duty process for a variety of groups ranging from EAP management consultants to occupational health supervisors and labor relations managers. Today's presentation is approved for 1 credit hour of continuing education for CSAPAs and CDAPAs from SAPAC. Further information will be provided at the end of our presentation. It will now be our pleasure to hear from Bill Current and Laura Lacey-Dashner.
Well, thank you, Jessica, and welcome to everybody on today's webinar. Really excited about this topic and to be co-presenting with Laura. I've known her for many years now, and I've gone over the slides that she's going to be working from, and I'm really excited to hear her part of the presentation. Just as an overview, as a starting point, we're going to talk a little bit about the sort of comparing the difference between having somebody test positive for drugs and letting them go versus putting them in some type of, or them going through some type of substance abuse treatment program and then coming back to work, being subject to a return to duty test and a follow-up testing program. And we're going to talk a little bit about the costs of those things and get into some of the policy issues if you're dealing with it from the employer standpoint. First, we'll start out with and I'm just going to really sort of brush over these quickly. It's just to make the point that the substance abuse problem in our country is still there, it's still prevalent, and in fact, in many respects, it's a growing problem. And so we've put some statistics into the slide presentation that you can look at later because you'll have access to these slides so that you can go back, look at the information that's available from SAMHSA, the Substance Abuse and Mental Health Services Administration, and from the National Survey on Drug Use and Health, and look at the numbers for yourself. But you'll see that even though it's been fairly steady for the last couple of years, the last few years, the rate today is significantly higher than it was in the early 2000s. And so there's a lot, a movement of, a tenth of a percent, but certainly of a whole percentage when it comes to the millions of people that live in this country. It represents a significant increase in drug abuse, and a lot of it is fueled by the significant increase in marijuana use at virtually every age category. And so these numbers are here for you to look at your own leisure after we do the presentation. and you get the slides. I do want to point out something very interesting, though. That second bullet, the second most common drug of abuse after marijuana is the combination of all the non-medical uses of psychotherapeutic drugs. We're talking about pain relievers, tranquilizers, stimulants, sedatives, etc., all lumped into one category, actually outpace cocaine, opiates, etc., as the second most abused category of drugs in our country, and that's a significant development. Now, when you're looking at this from a cost perspective, you have to look at what it costs you to replace a worker. And there have been a number of studies done. What I've done here is I've found a source that had looked at quite a number of case studies on the cost of turnover. In the first bullet, 27 case studies, in the second bullet, 22 case studies. And you can see that in each case, the percentage of the salary that you're replacing that it takes to replace somebody is fairly significant. Of the 27 case studies that were studied in that first bullet, 21% of an employee's annual salary is what it costs to replace that worker. And then there's 22 other case studies, probably overlapping, that talk about the percentage broken down by annual salary. So I'm going to just go to this chart on the next page, and you'll see the three bars on the right show the percentage of somebody's annual salary if they're making $30,000 or less. It's about 16% of the amount that you're paying that individual to replace them. About 20% for somebody making $50,000 or less, or about a little over 20% if you're replacing somebody at $75,000 or less. So it's a fairly significant cost to replace a worker, and you have to ask yourself, is it worth doing that, or is there a way to retain that worker who perhaps has a substance abuse problem, who's willing to go through some type of a program so that they can come back clean and ready and bring their experience and their skills and their training and the investment that you've made in them to bring all of that back to the workplace? Now, one of the questions that always comes up, of course, when we talk about this issue is, the relapse rate, the recidivism rate of somebody who goes through a program successfully and then perhaps has a problem. They relapse. And so this is information from the National Institute on Drug Abuse, from NIDA, on relapse. And the question that they pose, and I think it's a significant question, is when somebody relapses, does that mean treatment has failed? And the answer to that is no, not necessarily, and most of the times not really. And what I put here, the chronic nature of the disease means that relapsing to using drugs again is not just possible, but probably likely, that it's going to take a series of exposures to treatment before somebody perhaps successfully is able to leave that behind. And if you were on the webinar I did last month on cotinine testing smokers for nicotine, we talked about the recidivism rate of going back and smoking again, and it takes several efforts before a lot of people are able to successfully quit smoking, and the same applies to other things. In fact, that second bullet shows that the relapse rate for drug addiction is pretty similar to other chronic medical illnesses. And I'm going to show you that on a slide here. This compares drug addiction to type 1 diabetes, to hypertension, and to asthma. And you can see that the relapse rates are very similar. I mean, yeah, it's a little bit lower for diabetes, but less than hypertension and asthma. So that's important to keep in mind, that the treatment doesn't necessarily, if somebody relapses, it doesn't mean the treatment necessarily failed, but it might mean that some adjustments need to be made to the treatment program, or maybe a different type of treatment program would be best for this particular individual. Now, the American Society of Addiction Medicine, ASAM, has looked at this very, very closely and have come to the conclusion that drug testing can be a very effective component of a treatment program as well as an after-treatment program. To put it in their words, if you go down to the second bullet, drug testing can be an effective therapeutic tool to assist in contingency contracting or other behavioral therapies. And very importantly, in the third bullet, it can also serve as a deterrent to going back and using drugs again. I like this final bullet here. Let me just point out in the third bullet, especially if specimens are collected, in other words, if drug tests are performed on a random basis. And then periodic drug testing can be part of a clinical protocol or practice guideline in some addiction treatment services. I put this in bold. ASAM recommends the use of drug testing where medically appropriate in clinical treatment settings. Now, they do talk about the frequency and the duration of a drug monitoring testing protocol, and they also, make the caveat here, and I think this is good advice, that all positive screens should be verified through a confirmatory testing process. And in the workplace, that's pretty common practice. We typically don't make disciplinary decisions or other type of adverse employment decisions based on a screen drug test. We always confirm before we take action. And so they're recommending the same thing. Of course, that's good advice. And in many cases, it's required by state law. Now, I'm kind of breezing through a few of these because we've got a lot of slides. I want to make sure we get through as many as possible and that I leave Laura enough time for her part of the presentation. Then we'll have some Q&A after that. Just so that we're all on the same page, let me just give you a brief primer on what follow-up and return-to-duty drug testing are. Okay, and then I'm going to show you the DOT definition for those of you who are involved in the workplace. Both follow-up and return-to-duty testing occur after someone has left work and is now coming back after having successfully completed some type of a treatment program. Return-to-duty is a one-time test. Okay, that occurs before the individual returns to their position in the company performing perhaps safety-sensitive duties, which of course is always the case with DOT. Okay, they've got to be able to produce a negative return-to-duty test result before they can resume their duties. Follow-up testing occurs after that. This is typically after the individual passes the return-to-duty test and has now started working again. Okay, it consists of a series of tests over a period of time. It can be lots of different things. There are some state laws that dictate the number of tests and the amount of time. The DOT regulations provide guidance there, but all of those things are sort of subject to change. Now, according to one laboratory's report, okay, this is just from one major laboratory, about 3% of DOT-mandated follow-up drug tests were positive in the first half of last year, but among non-DOT mandated follow-up tests that were conducted by company choice, if you will, the rate was 6.5%. So you can see, even at 3%, that's significant, but 6.5%, that's a fairly significant percentage. So it's certainly worth doing follow-up drug testing, but it's always important that you check the state laws that apply to you before you implement a program. Now, if you're under the DOT regulations, you have to do it the DOT way. And the DOT defines return-to-duty and follow-up testing as this: conducted when an individual has violated the prohibited drug and alcohol conduct standards and they've now returned to performing safety-sensitive duties, or they want to. Follow-up tests are unannounced. There's usually at least 6 tests conducted in the first 12 months after a driver, in the case of the Federal Motor Carrier Safety Administration regs, returns to duty, and the follow-up testing can be extended for up to 60 months. You can find information about that in 49 CFR Part 40, and in particular, in Subpart O, you'll find information. It's a fairly lengthy section, but very worth reading, information about substance abuse professionals and the return-to-duty process. And I'm going to go through a little bit of it here, not a lot, but just a little bit, because I want to point out the fact that, and I'm going to go through a state law explanation here in a minute as well, not a lot of states provide much guidance when it comes to the return-to-duty process. Sometimes they punt altogether and refer to the DOT regs or to SAMHSA and don't include anything on the return-to-duty process in that state drug testing law. And so, by de facto, Subpart O, the substance abuse professional part, but even more so the return-to-duty process, has become sort of a gold standard. Now, I'm not suggesting that you have to do it this way when you're not under the DOT mandate, but it is a process that's out there. It's being used by hundreds and thousands of employers, and it's been proven to work in terms of the process. It doesn't necessarily always mean that the person does not relapse, but it's a process that an employer can use in their company, follow, and have some sense of security that, the process that they're following is valid and there's integrity in the process. Now, what's a substance abuse professional? Well, here are the credentials, in Subpart O, and you can see they're pretty impressive list of professionals here. Licensed physician, licensed certified social worker, licensed or certified psychologist, etc. I want to point out that it says, you know, in describing it, you are this or you are that, and that means that you've got to currently be licensed as a physician or as a psychologist or as a certified social worker, etc. And then the number 6 at the bottom there, you are a drug and alcohol counselor certified by the National Association of Alcoholism and Drug Abuse Counselors Certification Commission, by NADAC, or by the International Certification Reciprocity Consortium, Alcohol and Other Drug Abuse, or by the National Board of Certified Counselors, Inc., and Affiliate Masters Addiction Counselor. So there are several different certifications that you can have and qualify as a SAP, but you've got to be one of these things, okay? And it can't be a past thing. You've got to be a current one. And you have to be able to show that you have certain basic knowledge of the diagnosis and treatment of alcohol and controlled substances-related disorders. That's a lot, of course, but you also have to be familiar with the SAP function. Now, of course, we're talking under the DOT regs. The SAP function as it relates to employers in these safety-sensitive duties, and you have to be knowledgeable of the part of the regs that applies to the employer that you're working with their employees. So there's a lot to it. I mean, the substance abuse professional is a pretty important part of the whole process. May not be necessarily required outside of a DOT setting, but it is somebody who's qualified to do this type of thing. And there's more in the regs, a lot more in the regs that you can look at. It's worth going back and reading that as you kind of take all the information that we're presenting here and perhaps adding a follow-up testing program to your drug testing policy. And let me just say this at this point, because we're stepping now into the state law section, is that our core business at WFC and Associates is writing drug testing policies. We write them all day, every day, you know, every week. A lot of companies, or I shouldn't say a lot, but more companies than I would suspect or would predict don't include follow-up drug testing in their policy. They may do return to duty testing, but then they leave out follow-up testing. In some cases, they leave out return to duty, but they do follow-up testing. And you have to make that decision for yourself in a non-mandated situation. But I think it's very valuable. I think it's worth doing, especially if you're interested in helping people who need help. Now, and, you know, sort of recapturing the investment that you've made in that individual before you let them go. When it comes to state laws, the good news is there's just really a couple of instances around the country that you've got to be hyper-sensitive about. One of them is in California, and I'm not saying these are the only ones, but these are the two that stand out the most to me. California, a state that doesn't actually have a drug testing statute, but there's so much case law in California, and there's a very strict privacy law in California that I think make it challenging to do both return to duty and follow-up testing. And so typically, we'll at least advise a client of this information and suggest that they maybe limit this type of testing to workers in safety-sensitive occupations, okay? Boulder, Colorado not having an actual statewide mandatory drug testing law, but the city of Boulder having a drug testing city ordinance has some restrictions on follow-up testing, that it has to be part of an employee assistance program and that the individual has to agree to participate in that program. And that may or may not always happen. And so Colorado's a little bit more like California in that regard. Keeping in mind, okay, that's the theme of our presentation today is not marijuana, but keep in mind that Colorado not only has a medicinal marijuana law, which makes it legal for certain people in certain circumstances to use marijuana for medicinal purposes, but along with Washington, it became one of the first two states ever to make marijuana use legal, period. We sometimes refer to them as recreational marijuana. Well, I say that because as it applies to other types of drug testing situations, you run into sort of a more liberal viewpoint or a more liberal approach to things like drug testing. In every other state, municipality, or territory, return to duty and follow-up testing are fairly open. I'm going to give you a couple of examples. There are 8 state laws that provide guidelines or conditions for return to duty testing. Okay, they don't prohibit it, They don't really even restrict it severely, but they do provide guidelines or conditions that you have to comply with. In some cases, they actually, like I said earlier, they just sort of punt on the issue and they refer to the SAMHSA guidelines or to the DOT regulations. They may require the use of a laboratory, certain things like that that are probably already in place for other testing circumstances as well, like pre-employment or random testing. Ohio's law is a little bit different. It actually requires return to duty. It's a voluntary law, okay? So only companies that want to be in the workers' comp premium discount program are required, if they get into the program, they're required to comply with all of the components of the regulation, including the requirement to do return to duty testing. Now, there are 16 states that offer guidelines or conditions on follow-up testing, 8 on return to duty, 16 altogether on follow-up testing. And these again are fairly general, okay? They establish the employer's rights to actually require follow-up testing, but at the same time, there are some minor restrictions for the most part. I'll give you one example. Alabama, which again is a voluntary law state, okay, it requires follow-up testing of employees who complete a rehab program to which they were referred after failing a drug test, but prohibits this type of testing for those who voluntarily enter treatment. Okay, so somebody voluntarily enters treatment without failing a drug test cannot actually be subjected to follow-up testing when they come back to work. Someone who fails a drug test and goes into treatment, they can be required to go through follow-up testing. A little bit of a different twist in Alabama than you'll find in most states, okay? When it comes to the substance abuse professional, Alabama and Arkansas are actually just 2 of 7 states that require follow-up testing as part of a mandatory voluntary drug testing law. And employers that fall under those workplace drug law, they actually have to conduct follow-up testing in these states. These states are states that actually require it. And I'll leave it for you to go through there when you have a chance, just to kind of keep the pace of the webinar moving. I do want to make a statement, though, about policy. I can't resist, of course. That's my area that I spend most of my days in. And I'm not suggesting you use this language, okay? But this is an example of some language that you can include in a policy. Employees who test positive for drugs and or alcohol for the first time will be referred for substance abuse assessment to determine the need for treatment. So you're going to leave the final determining factor to a professional to make an assessment for the need for treatment. Employees who successfully complete recommended treatment may be eligible for rehire, maybe, okay, depends on the circumstances, and if rehired, may be subject to follow-up testing. And I put in parentheses, employees must submit a negative return to duty test before being rehired. So in your policy, you would have a section on return to duty testing that would describe how that works and under what circumstances you're going to conduct a return to duty test. And then you're going to have a second section that applies to follow-up testing. So I'm just putting in brackets here the fact that you're going to require a negative return to duty test before the employee goes into a follow-up testing program. And just like under the DOT regs, the follow-up testing is going to be unannounced. It's going to be random. You may follow the DOT standard here of 6 follow-up tests during the first year, during a 1-year period, I should say. But maybe not. Depends on what your state requires. And you're going to follow the recommendations of a professional. Okay, so as an employer, you're not going to try to put that hat on and somehow, make the case that you're the expert and you can make that determination. To protect yourself and to protect the integrity of your program, you're going to let somebody else make that decision, somebody who's qualified in that particular area to do that. Now, at this time, I'm figuratively going to turn the microphone over to Laura, and she'll take us through her part of the presentation, and then we'll come back at the end of her remarks, go through a little bit more information, and then have a question and answer period. So, Laura, I'm turning the mic over to you and transferring control of the slides to you as well.
Great. Thank you, Bill. Well, I'm very excited also to have a chance to talk about this. As a social worker and a substance abuse professional and clinician, we are always looking for ways, the best way to help people. And what we found here at ASAP is that one of the most successful models for recovery for folks who have been through treatment is an employer-sponsored follow-up program. So Bill had spoken a little bit about relapse, and relapse is a part of treatment. what we see, and employers are often intimidated by that, but what we see in our programs is that employer-sponsored programs and follow-up testing give those employees the very best chance to make that transition to long-term abstinence and a successful recovery lifestyle. So let's start off by taking a look at what the sample policy that Bill was talking about a few minutes ago would translate into in terms of what it would look like from the employer standpoint. So how would that actually work in process? So under the policy, the employee has demonstrates the prohibited conduct, in most cases a positive test. The employee is referred for an individualized assessment. That evaluator who does the assessment is a qualified evaluator, determines the need for treatment and what that should be. The employee goes to the treatment, is successful, successfully completes that, successfully completes a return to duty negative test, is eligible for rehire, and then once they're rehired, the employer then implements the follow-up testing plan that has been determined by the evaluator. And again, this is loosely modeled on the DOT return to duty process, and the reason it is that it's a good process. It works very, very well. So, so does the second chance policy like that? Does it work? Is it successful? And what we have found is that it's very successful. So, for instance, we have one company that is a large national company. They make hundreds of referrals a year in non-DOT, non-mandated positions under their second chance policy. And what we find is that 85% of the folks who come into the program successfully complete their treatment, which is a very high percentage compared to national averages of how many people complete treatment on their own. And that 85% gets back to work successfully. And after that, and I think this goes along with the statistics that Bill quoted earlier, only about 6% will have positive follow-up tests in their follow-up program, which is typically 2 to 3 years long. So it's a very successful program. And so when you're looking for something to give employers some assurance about the success of a second chance policy, employers aren't experts on substance abuse, and they shouldn't try to be. But we look to the experts. We look to the researchers. And even though ASAP has had this experience for, the last 15 years of how successful it is to have this sort of long-term follow-up testing, what we're finding now is that the researchers are catching up with us. So a little bit from the National Institute on Drug Abuse, talking about the goal of treatment. Treatment obviously is to help people stop using drugs or whatever their drug of choice is, or alcohol, but it's much more than that. So the goal of treatment is to maintain a drug-free lifestyle and to achieve productive functioning. And people typically aren't going to get well if they go to 5 days of detox and have no treatment after that. That's not going to help. That results in high rates of relapse. However, when people have long-term care, they are able to achieve, they're most likely to achieve that goal of sustained abstinence and a long-term recovery where they can achieve successful functioning in all the areas of their life, not just their work, but their home and their family. That's also echoed by SAMHSA, the Substance Abuse and Mental Health Services Administration. They collect a tremendous amount of data every year, thousands and thousands of, tens of thousands of pieces of data on treatment admission and discharge and success rates and who is successful. And again, what they found is regardless of what the drug is, regardless of what the treatment modality is, meaning the type of treatment they receive, the one piece that is very consistent is the longer people are in treatment, the greater their chance for success is. And I would argue that long-term follow-up testing is a type of treatment. It's contingency management. So people get to continue working in their job if they can continue to test negative and not use drugs. And that's a very strong motivator for a lot of people. So it offers a structure and accountability to folks that helps them achieve that long-term goal and be very successful. Here's another slide talking about, at one point, Chevron Corporation conducted a study among the accident rates of their workers. And what they were trying to decide is whether they could put people who had been in rehabilitation into highly safety-sensitive jobs. They had some concerns about that. And what they found was people who were in a monitored substance abuse rehabilitation had no more accidents than did regular people, their regular population who had never been in treatment. But it is predicated on having a rigorous follow-up program involving heavy testing. So folks who have been in rehab can be very successful workers. You can retain that investment in training, and you can have a rigorous follow-up testing, have very safe employees. So we can move now. Now, the next slide is talking. Is written by a couple of researchers, Drs. DuPont and Humphreys. They assert 3 basic principles for care management that lead to the best long-term outcomes. And this supports absolutely everything that we've been speaking to. These are the 3 main points of very successful treatment. Programs that last for an extended period. Substance abuse being closely monitored through extensive testing. And use of drugs actively managed through consequences. And again, in this situation, the consequences for using would be loss of employment. A very, very strong motivator for people. So these 3 points almost exactly describe the process that we started with. So we've got long follow-up that lasts for 1 year up to several years. There's testing, and there's a contingency involved. Very much a recipe for success. The new paradigm advocates for the use of intensive and extensive drug and alcohol testing as a tool to monitor continued use. The Intercept offers strong advantages to employers in the second chance scenario here. One of the biggest barriers to being able to do that kind of extensive testing is just logistical. Are we going to stop production while we get them to the collection site? Are they going to have to wait an hour to have their test? They don't like the testing. There's sort of a yuck factor to it. They can cheat. All of those things are mitigated by using the Intercept and the advantages of that. So collecting anytime, anywhere, being able to do it on site and not, obviously privately, but on site, and eliminating all the observed collection hassles, and certainly eliminating that cheating with adulterants, dilution, substitutions. All of those factors make it a great tool for this type of program. So to go back to the research, again, the proof that it actually works. The researchers who developed the new paradigm took a look at 3 programs, and I think what originally sparked their interest in that type of program was the physician's health programs. When a physician has been identified by their medical board as having a substance abuse problem, they are entered into a very rigorous program to be able to get their medical license back, and once they've gotten it back, to be able to continue to practice medicine. The same thing is true of pilots. We work with pilots here at ASAP as well. We have the same sort of very intensive monitoring programs for those folks. Obviously, their well-being directly impacts a lot of other people. And physicians' health programs are incredibly successful. They monitor people very closely. There's a weekly testing. There's a counselor follow-up. Those programs are very successful. So the researchers started with that, but then people said to them, well, physicians are very motivated. Those are, people who are very, very motivated. They're obviously very bright if they've become physicians. They may be different than everybody else. So the doctors decided, well, we're going to take 2 other programs that are very similar who are working with a different population. So they looked at a sobriety program that managed repeat DUI offenders, and they also looked at a probation program that was looking at convicted felons who are on probation. Same type of program management, though, for all 3 of those populations. And what they found is that all the 3 programs were very successful. 81% of the physicians were abstinent for 5 years of monitoring. The probation rate was even higher. 85% of those folks completed that program for 6 years. And the DUI monitoring program, their full compliance was a little bit lower, but all of their tests were virtually all of their tests were negative. So, so all of those programs very successful with very different populations of people using those principles. And the hallmarks of these programs are Dr. Reed Morrison and Dr. DuPont, who wrote the new paradigm, recently wrote an article for the Journal of Employee Assistance in which they pointed out the similarities of the new paradigm to the DOT substance abuse professional return to duty process that Bill was talking about earlier, that we've sort of loosely based all of this on the process. And that process is summarized by individualized assessment by a trained professional, individualized treatment referral, so the assessor makes a referral for treatment based on that person's needs. So there's not a blanket, everybody who has a positive test has to go to 30 days of inpatient. That's not how it works. They go see someone who's trained, who is a professional, who knows about substance abuse, and who can say whether this person should go to inpatient treatment, whether they should go to outpatient treatment. Perhaps they only need an education program. So it's an individualized treatment referrals and recommendations. And at the end, there's a follow-up assessment that results in a testing plan. So that process is very similar to the new paradigm, and that the hallmarks of those policies are individualized assessment, opportunity for treatment, individualized follow-up testing plan, and clear boundaries and consequences for the continued use of prohibited substances. And I want to focus on that individualized piece. I think that for employers, individualizing this process for each person, rather than saying everybody's getting 6 tests if they get out of treatment, everybody's getting this, individualizing it is a very strong point that creates a defensibility from a legal standpoint in terms of this person that had a professional who evaluated their treatment program, evaluated their progress, and recommended these number of tests as a prescription to help them maintain their long-term recovery. So who should provide those assessments? Like Bill, what we do at ASAP is Bill provides policies, we provide assessments, and that's what we do. So we obviously want to have understanding of who's the best person to provide those assessments. You know, should an employer send that employee to the local treatment center and let them do that assessment? Who should do that? From our experience, what we find is that a substance abuse evaluator needs to understand who the client is. Now, that is an important piece. So if the evaluator knows that the highest priority of this evaluation is to protect workplace safety, they are going to evaluate that client a little differently than they might if it was just the client in front of them. So sometimes if you went to see a counselor and you were not there for a workplace issue, the counselor would look at you and think to themselves, wow, here's somebody who would benefit from extensive treatment, but I don't think they'll go to that, so I'm going to recommend them to something that they will go to. That's very different in a workplace assessment. If I see someone for a workplace assessment and I see them and I think, wow, they really need extensive treatment, and even though I'm not sure that they'll go, I'm going to recommend it because that's what needs to happen for this person to be a safe employee. So you want an evaluator who understands who the client is and that workplace safety is of the highest priority. You need an evaluator who doesn't have a financial interest in providing treatment. You know, that people come back, well, he only says I have a problem because they want me to pay for treatment. Having an evaluator who's an impartial third party is a great benefit there. And you need an evaluator with verified credentials and experience. You need to know that person has been trained, has an updated license, has the experience in the treatment, diagnosis, and recommendations. From our experience, we find that people who are qualified to act as DOT SAPs are a great choice because they meet all of these criteria. So that's typically how we do it, but those are the criteria that make a good assessor in that scenario. And finally, I would say the benefit to the employer and the employee, I have employer and employer, but employer and employee here is so, so strong. Work is a powerful reinforcer of positive behavior. People want to work. They want to stay in their jobs. And that is a strong, strong motivator. People who are working to maintain sustained recovery from substance abuse benefit from the structure and accountability of long-term follow-up and monitoring. And a well-managed second chance policy gives that employee the greatest chance for success. I think sometimes people look at employer-sponsored follow-up programs as punitive. They're punishing me with follow-up testing because I made a mistake and had a positive test. And from my perspective, nothing could be further from the truth. We see that follow-up testing is such a benefit to the folks that participate in it, and it really helps them reach that long-term goal. People who have been in treatment who need to make that transition from clean, I've been through my 30 days of treatment, I'm clean, but they need to make that transition to sustained abstinence and a recovery lifestyle. Need that kind of monitoring is a huge help to them. So from my experience, from my position, I think that follow-up testing is just from a humanitarian perspective an amazing thing to offer your employee population. So that wraps it up for me, I'm going to pass the slides back over to Bill and let him say a little bit more about his part of this.
Now, Laura, while I've got you on the line, let me ask you a couple of questions. I took some notes. Fascinating, great information. From your experience, and obviously you're in this part of the business, so the companies you deal with are committed to doing at least the assessment, if not follow-up testing. But from your experience, outside of a DOT situation where it's mandated to do X number of tests for this many months, et cetera, what would be sort of a common or typical follow-up testing program? How many tests? How long would it go on? And what role would you play in that process?
Well, speaking as an evaluator, because I also, in addition to what I do for ASAP, I also do some evaluations in the office. Those recommendations for follow-up testing are always based on the clinical assessment of that individual. So if someone has come in who has maybe struggled in treatment, possibly has a history of treatment in the past, someone who needs a lot of support, that person, might get several years of follow-up testing and enough follow-up testing that they aren't going to use drugs without testing positive. So they may have a heavy schedule. So I hesitate to say that there's a typical recommendation for testing. We have looked at it, and I think that we found that probably 50% or 60% of folks have 2 years or more recommended for them in a non-DOT setting. So I think 1 year is never a good idea. I don't think 1 year is a good idea because most of the time people believe that their testing is 1 year, and it's not as they sort of start counting tests and doing some stuff like that are not. So it's more helpful to them to think it sort of goes on into perpetuity.
Yeah.
It's going to last a year, maybe even longer.
And you made reference to the percentage that I used at the beginning of a 6% positivity rate for follow-up testing. Is that affected by any other factors? In other words, do certain industries, workers in certain industries have a higher positivity rate versus others? I mean, what factors come into play there?
I think it really comes down, from my experience, is to not the skill level of the job, but how is it a good job? So, the folks that we're working with that are having 6% positivity rate are people who in this particular company hires people at entry level. They spend a lot of time working their way up. Those are very good jobs. So, to some extent, the more motivating the job, it can be helpful in that. So, if you have people who are day laborers, they don't tend to be as invested in maintaining that employment as somebody who's been in a job a long time and really wants to make it work.
Now, what about companies that have, and you hear this all the time, of course, and I deal with it, in the policy end of the business, that want a quote-unquote zero-tolerance policy. There must be, I can speak to it from a policy issue, but from your perspective, your part of the industry, how do you respond to that? Companies that just want to
we hear
fire
a lot
anyone
of
who's positive.
Right, and I'm sorry, Bill, can you repeat that?
No. Just, companies that just, in every circumstance, they just terminate.
I think that goes back to what you started with, is what's your investment in the employee? If you are invested in these employees, if you have, spent years training them, or do you really want to throw that investment away when conceivably you could have, it's a win-win. The way a second chance policy works is, if it's written well and crafted well and monitored well, the employer wins either way. Either you have the person fails, because if they are not going to get sober, they will fail, and you don't have an unsafe employee in your workplace, or you get your experienced employee back and they're better than ever. So it's sort of a win-win to me. I'm not sure, I understand why people sort of maybe shy away because they think it's too complicated, but I think it is a strong investment in your workforce. Perfect.
Thank you. Now, I've got a couple other questions. I'm going to save them more towards the end. I do want to take just a few minutes to talk about lab-based oral fluid testing. Laura talked about the Intercept device, which is a lab-based oral fluid testing device. Let me just say, as I launch into these next few slides, that, and if you've ever been on any presentation I've done, I'm a proponent of all types of drug testing. So I think under specific circumstances, a specific type of drug testing method will be right for you. So it's never a matter of picking the best one, it's picking the one that's best for you under your circumstances. And as some of you on the webinar probably are aware, the federal government's in the process of developing regulations for lab-based oral fluid drug testing to be part of the SAMHSA guidelines. And this is a very interesting time in the drug testing industry. I do a survey every year of the industry to sort of identify trends and things that are going on and predictions for the next year, et cetera. And I just presented that at the SAPA conference a couple of weeks ago, the results of this year's survey. And one of the things that came out, one of the probably 3 or 4 really hot issues from this year's survey was, where is the federal government in terms of the development of these lab-based oral fluid testing regulations? And there were some representatives from the federal government, from DOT. Patrice Kelly was there. Donna Smith, who's not with the federal government anymore, but also made a presentation as well on the whole process with the Drug Testing Advisory Board and where that's at. And it's still a little bit of ways out there. They're still working on the language for the regulations, so we're probably not going to see anything next year perhaps in terms of a final regulation, but hopefully maybe some proposed guidelines. But this is in process, and this is significant because it's been, since the beginning of time, since DOT has made a significant change of this nature, or the federal government, I should say. DOT would be, phase 2 of an adoption of lab-based oral fluid testing regulations. They would be after this process. But to allow another testing method, in this case lab-based oral fluid testing, maybe down the road hair testing, is fairly significant. Outside of the DOT regulations, though, we see oral fluid testing and hair testing and point-of-collection testing taking place in virtually every industry because there are certain strengths or advantages to alternative testing methods, if you will, alternative to lab-based urine testing, that just fit well with certain workplaces or certain industries, certain types of occupations. And so with lab-based oral fluid testing, when you ask people in the business, as I did with my survey, what are the advantages? What are the things that are clicking with buyers? It's the fact that it's not urine. And again, I say that as somebody who's a fan of urine drug testing. But it also, as Laura talked about, it's virtually impossible to cheat on an oral fluid test. The collector and the donor are right by each other the whole time within sight of each other, so there's no way to really sort of switch samples. You really can't add something to your mouth to sort of dilute the specimen, et cetera. The person's not, you can do an oral fluid collection and test right on site. There just takes a few minutes, and then you send the sample off to a laboratory to be analyzed. And so the lost productivity that's sort of inherent with lab-based urine testing where the collection takes place at an off-site collection site, that sort of goes away altogether when it comes to lab-based oral fluid testing where you can do the collection right on site. And you're also getting a lab-based result. And I think that's what the federal government likes about lab-based oral fluid testing versus maybe POCT urine or POCT oral fluid testing. They like still being able to get that lab result, but being able to take advantage of some of the collection benefits of oral fluid testing versus other testing methods. And so, you can go through sort of a whole list of advantages of oral fluid testing, especially on this slide when it comes to the collection issues. And so it then becomes a matter of which testing method is best for you. And as Laura talked about, when you're in a follow-up drug testing program and you're conducting 6 or more drug tests over a year or 2 year, or they're a form of random testing, but the individual's back from treatment, they've passed their return to duty test, they're subject to follow-up testing. So as Laura talked about, that motivators in place to not relapse so that you can keep this job that you like, because she talked about the fact that if it's a good job, you're going to be highly motivated to want to keep it. So you made a mistake, you slipped up in the past, you got caught through the drug testing program, but now you're subject to this random follow-up testing program. You want to keep this job. Well, you as the employer want to keep this worker that you've, kind of stuck it out with, you want to keep them on the job. And so oral fluid testing makes it possible for that individual to be off the job maybe for, say, let's say 15 minutes to participate in this random oral fluid test that just came up versus sending them to an off-site collection site where they may be gone for an hour or more. And so that becomes a very appealing part of oral fluid testing. And I think under certain circumstances, there are companies that are going to be very interested in this. Now, I think you're already seeing this sort of migration toward these alternative testing methods, and in particular lab-based oral fluid testing, because of where the federal government's going with this. But there are just a lot of companies that, you know, urine testing just really over the years hasn't met their needs. It's just not a good fit, and so they've been reluctant to do it, or maybe they're doing it, but they're open to a different way of doing it. Maybe they're in a situation where you've got to, you know, sort of justify every expense of that you have in your company, including drug testing. A lot of companies are in that boat right now. And then there are just a lot of companies that are in situations where a traditional urine collection is just inconvenient. It may be costly. These may be companies that are running 24-hour shifts. They're out in rural locations where sending somebody to a collection site could be, you know, quite a drive to get there, et cetera, et cetera. And so oral fluid testing represents an alternative, especially as it applies to companies that are in these circumstances that, you know, are worth considering. So I have found through the survey and through working with companies that these are the industries that, they're not the only ones, of course, but these are the industries that have shown more of a propensity towards oral fluid testing than perhaps other industries. And you can see sort of a common thing, not among all of them, but construction, manufacturing, where you've got the safety-sensitive factor. And then also you have a lot of turnover in the retail industry, in the staffing industry, et cetera, where those become factors. And it's not just in the workplace. It can be in, you know, what we would refer to as other workplace or other drug testing markets, especially in criminal justice, for example, or schools. That's another one where you're starting to see more of an open mind to alternative testing methods. And so want to just express appreciation to OraSure for putting on yet another great monthly webinar, and now open it up to questions that you have posed to us. And Laura, I'm going to pose the first question to you that was sent in, and I think you're the best person. I'm not sure how to answer this, but somebody presented a very good question here, which is, does individualized treatment sometimes get interpreted as discriminatory?
I think it's exactly the opposite. So I think that if you're using a qualified evaluator, you avoid the discriminatory aspects of that. So that actually is one of the things that people have focused on in doing these kind of second chance policies, is that it should be individualized. That's a great defense and a very good question.
Okay. And you've used that term second chance policy a number of times. Can you give us a little bit of insight in sort of the content of a second chance policy?
Pretty much exactly what we've described. So the idea of that is that folks have the opportunity, once they've made once they've done some sort of prohibited conduct under the policy, again, usually a positive test, they have that opportunity for a second chance. They get to go to treatment and come back and be in follow-up testing. They do not necessarily have to get a third chance. You know, so if they fail in follow-up testing, or they fail in the treatment process, they don't get to come back necessarily. They're not eligible for rehire. But giving them the opportunity to seek treatment and make a successful transition back.
Okay. Here's a question dealing sort of with the drug testing process, and maybe it's really sort of relative to state law, so I'll take a first crack at this. The question was, what about split specimens with oral fluid? There are states, and of course under the DOT regulations with urine testing, there's the requirement for a split specimen, and we can only imagine at this point, because the lab-based oral fluid regulations are down the road, that there would likely be some type of a split specimen requirement as part of those regulations. But in addition to that, outside of the Department of Transportation regs, there are a number of states, several states, I should say more than several states, that actually either have split specimen requirements in the state law, or they refer to the federal regulations for split specimen, for other collection procedures, for direct observation, circumstances, things of that nature. And so as an employer, it's kind of obvious, typical, here's how we do a split specimen with the urine, but how do we handle that with oral fluid? And it's kind of interesting to ask people who are in the industry right now how they're handling that. And in most cases, what I'm hearing from people, and you might see this advice or this guidance given to you, given by the oral fluid manufacturers, but the advantage of having a lab-based oral fluid test, in my opinion, as opposed to the instant oral fluid test, is you can actually collect two samples side by side. In other words, you can put we're looking at the screen right now, you can see, in this case, the intercept device, and you see the end of the stick there with the swab. That would go into the side of the mouth, and then you could simultaneously or sequentially do that process again and actually have another sample collected on a second swab. And send both of them to the laboratory, one to serve as the original and then the other to serve as the split specimen. I did have somebody describe to me the way that they do it and this was a company in the drug testing business that sells a lot of oral fluid testing, and the way that they deal with it is they actually put a swab on one side of the donor's mouth and a swab on the other side of the donor's mouth simultaneously and collect it that way. So, there's one right there that you can kind of consider. But here's the bottom line point, which is that, and you have to be careful about this when it comes to non-DOT testing, which is that as you look at a state drug testing law, it may have been written long before the advent of oral fluid testing, or hair testing for that matter, or POCT testing for that matter, but you're still required to comply with all of the components of that particular state law. So if they require confirmation testing, if they require MRO verification, if they require, any number of things, now that you're doing lab-based oral fluid testing, you would still be required to comply with those other parts of the drug testing law, even though it may not specifically refer to oral fluid testing. It's mostly because a lot of these state drug testing laws were written years and years and years ago. Some of them back in the 80s, some of them back in the 90s, but they're, mostly in the 90s is where you saw a lot of these laws written, the first 6 back in 1987, and then from then on. But a lot of them were written back before the day when a lot of the newer technologies of drug testing were available. I have a couple of other questions here. Laura, here's one for you. How specific should the company policy be in offering second chance opportunities? Maybe you have an opinion on that.
Specific about?
Yeah, I guess.
I think that.
Go ahead.
I think that if the policy states that the individual be giving is can take the opportunity or for treatment and is eligible for rehire under the following circumstances and may be subject to follow-up drug testing, that's as long as the opportunity is clearly there and the process is basically laid out, I think that would be specific enough. Okay.
And I think you've addressed this already, but this question just came in, so maybe it wasn't, they didn't hear the answer, but it's a recommendation in terms of how long should follow-up testing go for, 1 year, 2 years, and, and they even put on here 6 months. I think you kind of expressed that you felt like 1 year was not enough because you kind of start to count the number of tests and then, sort of the motivation factor may be gone once they kind of anticipate that there aren't going to be additional tests. Did I get that right from what you said?
That's my sort of clinical take on it typically, but I think that they're setting a minimum time is not a bad idea.
Okay. Here's an interesting question. This comes up a number of times. Excuse me. Do I have to hold the employee's job for them while they are in treatment? How would you address that, Laura?
That is a good. I think that is an individual decision when you're creating your policy to decide how that would be what would be the best way to handle that.
Yeah, and in some cases,
if it's a small organization, that may not be a reasonable step for that. It's really an organizational decision.
Okay. Yeah, I think you're absolutely right. especially if a company has hired a replacement worker and then, you're in the situation where you have one job for two people. So question posed here on the window of detection with oral fluid testing. The answer to that would be it would depend on the drug, of course. The window of detection for, say, THC, the psychoactive ingredient in marijuana, would be different than, say, cocaine. But typically the question is asked in terms of marijuana, so let me address it from that perspective. Usually you're going to have a window of detection of about 24 hours. So using that as a general statement, with the window of detection with oral fluid, the window of detection, if you want to look at it as a window, it opens immediately. Immediately after the person uses marijuana, let's say, on their lunch break or wherever, they very likely are going to test positive if you conduct an oral fluid test. Now, with urine testing, there's going to be about a gap of close to an hour before that window of detection opens, thereabouts. It could be a little bit less, could be a little bit more. But then that window of detection with urine is going to stay open longer than it will with oral fluid. So you're going to catch some people on the front end with oral fluid testing, and I use that term catch. I apologize, it's not really a matter of catching, but you're going to get some positives on the front end of that drug test that you're going to get with oral fluid that you're not going to get with urine. And conversely, you're going to get some positives on the back end of the window of detection with urine that you're not going to get with oral fluid. And studies have shown that it evens out pretty much to about the same positivity rate for oral fluid versus urine. Higher on the front end with oral fluid, a little bit higher on the back end with urine. And with THC, actually I've seen a number of studies that show the positivity rate for THC is actually just a little bit higher with oral fluid than it is with urine. I see that we're over the time. I apologize for that. We've had a lot of questions, so we're going to take all of these questions. We're going to respond to them for you, even though we don't have a time to do it during this call. But thank you so much for coming on, and thank you, Laura, for your excellent presentation. And I turn the microphone back over to Jessica.
Thank you, Bill. Thank you, Laura. On behalf of OraSure Technologies, we hope you have found today's presentation informative and helpful. This presentation was recorded, and you will receive instructions informing you how to access the recording. Today's presentation is approved for 1 credit hour of continuing education for CSAPAs and CDAPAs from SAPAC. Please use this unique identifier 01891309 CURRENT in association with that credit. Again, the identifier is 01891309 current, CURRENT. You may also email me at jessica@billcurrent.com if you would like the email certificate from this presentation. Again, that's jessica@billcurrent.com. Thank you for your attendance today. This concludes today's webinar.